My name is Dr. Tim Murray. I'm the founder and CEO of Solstice Health, and wanted to take a quick minute to thank the FMMA and Dr. Keith Smith for giving me the opportunity to speak up here. I think it was 13 years ago we opened our practice in Wisconsin, and the following year, as I was looking around digging for ways to learn more, I found the FMMA, and I was here at the first conference and sat somewhere around in this area with Dr. Smith and was able to talk to him afterwards and really just share some insights as to how we have similarities being both anesthesiologists and how he did what he did with the Surgery Center of Oklahoma, and told him about the practice that we had started with direct primary care and really wanted to, that was sort of the holy grail for me, was to open a surgery center very similar to his. And so as we talked, he went right to the Nike model and said, just do it. And so it took me a little while to do that, and we ended up doing that 10 years later, and we'll get into that. But I wanted to thank him especially just for his leadership in this space and all that they're doing for this free market medical mission that we're on. I thought this was a great quote. I really like it. It's amazing how much panic one honest man can spread among a multitude of hypocrites. I think that this is really important in this particular room because our goal with the FMMA and all of what we're doing is to really spread transparency, spread honesty, not only to the patients, but also to the market and the people that we're working with. So I found that to be interesting because with that, we do cause panic amongst the healthcare industrial complex, which is sort of what we're talking about today. I know we have monopoly as the theme. And I think it's probably a conglomerate of monopolies, and this is what they really look like. I think it's important to understand what this all looks like as we go through the process and really understand how these forces sort of work together, what they think is for the good of the patient. Hospitals, obviously, upper left corner is Frederick Medical College up in Wisconsin. That's where I train. Great campus. It's expanding all the time, and then a couple of other local hospitals. These are sort of the fabric woven within a lot of our communities that we see on every street corner, and you can see these things continue to build, and you start to wonder, how in the world do they keep building? We often talk about the not-for-profit hospitals. I like to call them not show-a-profit because they make enormous amounts of profit, and they end up continuing to build these clinics and hospitals, and now micro-hospitals. That's become a big thing because they have to spend their money. I won't talk about these too much. There's a lot of people in the room that are a lot smarter than me on the bucas, but this is just another component of the healthcare industrial complex. And then, of course, big pharma. Everybody knows about big pharma. We've got the top 5 major pharmaceutical companies across the top, and then the PBMs across the bottom. This is really, when you start to think about really the most important parts of what we're talking about, we like to look at the highest cost drivers. This is one of the highest cost drivers in medicine, and it continues to be, and it really has to be stopped. Administrative costs within this space are about a little over $1 trillion a year, which ends up being about 30% of what we spend annually, which I think this last year was $4.9 trillion. It comes in many forms: billing, insurance, coding, attorneys, marketing, middlemen, etc. And we often focus on the C-suite executives. And so I'm gonna do a little more picking on the C-suite executives today. So if you're in the room, don't raise your hand, but we can talk later if you'd like. Somewhere along the way, and I don't know where it was, someone told individuals that if you get an MBA, you know how to run healthcare. You know everything about healthcare. I want to assure you that you have no clue anything about healthcare. What you do know is how to hire consultants, and you do know how to have meetings about meetings, and lots of them. And that can be effective in certain things within the healthcare industrial complex. But what I'd like to submit to you is you don't know anything about patient care. You didn't go to medical school, and so therefore you shouldn't be telling us how to be treating our patients or what to be treating our patients with. And this was a good segue, I think, from Dr. Imes, so I appreciate that because it's much of the same ideas. you can be good at budgets and trying to run the hospital financial side of things, but when you implement those finances, you need to come speak to us first. You need to wrap your budget around what we want and what we need to be able to take care of our patients appropriately. Because there is no way that you can tell me how to do this job if you've never done it. So we really want to love you, but we really don't. And so please help us help you in really making this a better situation. It's important to stop the chaos of GPOs and all of these other things that are pigeonholing us into using certain instruments and tools in the operating room, for example. Some of the surgeons want to use a specific product and they can't because of these GPOs, and they have to buy certain products from certain entities. So it's really, really a bad way of doing business if you want to have good patient outcomes and be able to grow your business. This is a lot of what they like to do on the administrative side is they like to hire consultants, generally speaking, I think from Colorado. A lot of them, this is why we have Herb on the screen here. When I go into an operating room as an anesthesiologist and the lights are out and they're preparing and setting up all of their instruments and everything, and I have to ask one of the scrub techs, what in the world is going on? Why do you have the lights out? I know you've got your lights shining on your table, but why is the lights out? And they say to me, well, haven't you heard, didn't you get the memo? We're doing what's called a low light C-section now. And I said, well, that sounds really stupid. What is a low light C-section? And they said, well, it's better for the baby, it's better for the mom. It really creates an environment of just wholesomeness and love and warmth. And I said, well, do you understand that when they come in here, I have to do a spinal anesthetic. I've got all my medications set up. I have to be able to see those, and you want me to give the right things, correct? Well, sure, of course, but this is just the way we're doing it now. And of course I said, okay, turn the lights on. We're not doing a low light C-section in my OR. We're gonna do a full light, super bright C-section. We're gonna have a baby. It's gonna be amazing, and everybody's gonna go home. So of course I got called into the principal's office for that. And we had multiple meetings on that as well. And ultimately we ended up stopping that because it's not an appropriate thing for a consultant to come in and say, well, this is just gonna be amazing. It was in the newspapers. They did all this marketing around it. It's really, really stupid. Some of the things that I think are more concerning is when they start to push themselves into patient care. So a VBAC, what does that stand for? Vaginal birth after cesarean section. This is pretty important. There's a lot of nuance around that from a clinical standpoint. And a hospital that I was in, a rural hospital in Wisconsin at one point doing locums work, they were doing these VBACs. They do about 4 years, so pretty limited revenue in the grand scheme of things. And we went with the OBGYN department and the anesthesia department and said, guys, to the administrators, and said, this is really unsafe. We're in the middle of a cornfield. There are things that dangers associated with VBACs like uterine rupture and people bleeding to death and all those sorts of things. And we just think you shouldn't be doing it here. It's not a huge component of your hospital. So they said, nope, we're gonna do it anyways. If you don't like it, find a new job. And so we tried to push harder and say, do you understand that it's possible for patients to die as a result of this, or babies to die? It's about 4 hours to get blood, and if a patient is antibody positive, there's a whole lot of clinical nuance. And they said, nope, we're gonna do it. So what happens in those scenarios is hospitals or the healthcare industrial complex will call that a sentinel event. That sounds really cool and high end to say it's a sentinel event, and we call that death. And it's not a good thing for marketing. So you need to be listening to the doctors and what they're advocating for. So those are just some of the things that we have to deal with. But this is what we get all together. When these 4 entities come together, they push for a lot of unnecessary testing. Their hiring practices in the hospital, I think, are another area of concern because there's a lot of burnout and turnover. And the reason why is because in the operating room, for example, we might be down 5 or 6 people, but we churn out the same number of cases every single day because we go above and beyond and we push hard to get these things done. And the hospitals recognize very quickly, well, we're doing the same amount of work with less people, so let's drag our feet on this. And then they obviously have less overhead to pay for. So there's lots of different things. And I share these because I think it's important to recognize from our standpoint to see what's happening on the inside. I don't think a lot of people really know what goes on the inside. And so you're hearing it firsthand. Employment and non-competes, Dr. Imes touched on this. It's a really bad way of doing healthcare. The average primary care practice in the years past, in the past couple of decades, they were smart enough to know had about a 1% operating margin. And the minute they instituted EMRs and things of that nature, all of the primary practices threw up their hands and said, we're going to sell out. We can't do this. And so as a result of that, the specialists lost their referral source because that's who's referring to them. And ultimately, years down the road, the hospitals were then able to buy up all of the specialist practices, and now they own and control everything. And when they do that, they put non-competes on the physicians. So we can talk in detail about non-competes. I think it's at least being spoken about now at the federal level. There's been some pushback on it, but we'll see what happens as those things sort of get appealed. But they love sick care. If we have sick care, we make lots of money. If we have health care, we don't make as much money. But from a physician standpoint, and I think everybody else in the room that's partnered to the patient, which is brokers and plans and everybody else that's really affiliated with that, we have to be doing healthcare or at least trying to do a better job on that. And the price transparency, I think, is really a big part of the issue. See me afterwards if you want to talk about anecdotal non-compete situations that I've had to deal with, but they are real. I think people just need to have the courage to stand up against those and fight against those. The problem is if you're a small doctor like me, going against a behemoth like a big hospital system in Wisconsin that has deep pockets, and you're in court for 2 or 3 years, it ends up being a couple $1 million in attorney's fees, and it just doesn't work. So people are afraid to sort of go up against the beast. There's a lot of people that talk about doctors not being able to own hospitals. And I agree with them. It's insane. Lawyers can own law firms, plumbers can own plumbing companies, but a doctor cannot own a hospital. That was as of 2010 with the Affordable Care Act. But it's, I think, important to understand why the top 10 lobbyists, 4 of them are medical-related companies, pharmaceutical companies, American Blue Cross Blue Shield, American Medical Association. These are the top lobbyists, and they want to control the revenue generators. Guess who the revenue generator is not? It's not the administrators. It's not the hospital itself. It's the physicians and the nurses and the providers inside the hospital that generate revenue. So they want to control us because if they control us, then they control the cost. And so we really have to break through that mold. And in doing so, they also want to control and conceal the prices. 2021, they passed a law effectively talking about price transparency, and there was really 2 metrics associated with price transparency. One of them was to have a user-friendly format. So I took some screenshots of up in Wisconsin, and there's some, I blocked out the hospital names so as to not expose them. But you can see there's lots of hyperlinks. So if you like to be online and you can click on hyperlinks, that's super user-friendly. When you click on those links, this is what pops up. A lot on this screen, but I can tell you the lower right-hand corner, I did this 3 times, and I clicked on those links and my computer crashed 3 times. And I finally realized why it crashed was because the app for Word and my computer could not handle that document because it was 35,000 pages long. So that's why it continued to crash. But if you look in there, some of the highlighted numbers, you can go in all those numbers and all that coding and find that some of the hernia prices for some of these hospitals around $30,000 to $50,000. So the numbers are in there. And that's the metric that they use for now. The penalty associated with not doing that was $2 million max. The average hospital is about 130 beds, and the net patient revenue on one of those hospitals is around $224 million. So if you do the math, because they have a sliding scale with regard to how much you get charged for every bed over, I think it's over 30 or something like that, comes out to be about $500,000. $500,000 on $224 million is a rounding error, effectively. Then, if you move on to the biggest hospitals, the net patient revenue is about $3.6 billion. So that max amount that you could be charged at $2 million, again, is cost of doing business. And so it's really not something that people are working towards. They're just basically trying to manage and bob and weave through there. There is obviously some stuff going on in Washington. Healthcare Transparency Act in 2024, I think, is moving in the right direction, and there was now just an executive order passed, I think, in February, and most of the companies have about 90 days to respond, so we'll see where that goes. I hope it moves in the right direction, but I don't anticipate that it will. What do we get with all of this as they create this monopoly? Healthcare is about 20% of our gross domestic product. which is absolutely insane. Commonwealth Fund does a study every single year, and they rank the United States against 10 of the high-income countries, and they basically rank them against each other. Our access to care and health outcomes are number 10, so we're the worst on the list with regards to health outcomes. Administrative efficiency has gone up to number 9 from number 10 last year, so congratulations, administrators. And care process, I think this one's really interesting. Care process, when you look at what the metrics that they look at for this study, are a lot of preventative wellness, right? So we're very passionate about preventative wellness. And so you look at the mammograms and the vaccines and all these wonderful things that we're supposed to be doing to make patients better. So my question to any of you that has a brain, which all of you do, how in the world can we do the best or close to the best in care process and have the worst outcomes? I think we have to start to ask ourselves, are protocols the right way to do things? Is healthcare cookie cutter for each of you in the room? It's not the same for all of you. And so we have to start to look at how we can better care for patients on an individual basis, and pulling ourselves out of this system, I think, is the best way to do that. And we have obviously the number one healthcare expenditures in the world. We are, healthcare bills, we are part and parcel to the number one cause of bankruptcy in this country. 65% of bankruptcies are a result of healthcare bills, which I think is a shame. And coming from Wisconsin, we actually have the 4th highest healthcare costs in the country. I think probably in the next 5 years, if I had to bet on it, we're probably going to be number 2 or number 1 because of all these healthcare mergers that are going on. I think a lot of times these healthcare mergers, they do it with the notion of economies of scale, and we're going to drive down healthcare costs. It has never worked in healthcare. It will never work in healthcare. The more you merge and grow bigger, it's just not going to work. So changing your focus just a little bit, I want to just take a second to pause on all of that and change the way that you're thinking about this. Anybody in the room know who all 3 of these people are? Raise of hands. Anybody? Anybody out there? No. Okay, I do. That's Sean Penn, Kate Del Castillo, she's an actor in Mexico, and then Chapo Guzman. He is the infamous Sinaloa cartel drug lord. And he is obviously a ruthless animal. He's responsible for tens of thousands of murders, internationally, I would say. And so I wonder why these people are so interested in being close to him. There's a bigger story behind this. He actually got caught a second time as a result of this meeting. But they want to do stories about this guy. And I think to myself, why in the world would you want to sensationalize such a bad person? The reason being is because everybody loves him, okay? He is able to, and these drug cartels are able to create this Robin Hood effect to the countries where they live in. And I know this firsthand because I spend a lot of time in Mexico. My wife is from there, not related to the cartels, full disclosure. But they create this Robin Hood effect, and people talk about it all the time. They love these guys. Why? Because they invest money back into the community. They build hospitals, they repave the roads, they create jobs for all these people, and so they want them out of jail. So it's a really strange effect that they can create. And so I had to examine what the word cartel actually means. What's the definition of a cartel? And I think it's maybe a bit more fitting and frankly came from Keith Smith, 13 years ago or 12 years ago, and made this comment to me, and it really resonated with me. So when you look at the definition, there's several, but they're all very much the same. I like the last one: a group of independent market participants who collude with each other, as well as agreeing to compete with each other, not to compete with each other, in order to improve their profits and dominate a market. I think it's important to know that the word cartel, it has this association with drugs. It has absolutely nothing to do with that. This is just a general term. And so when you look at this term, compared even to the term monopoly is a single source. This is a group of independent market participants. So I wonder, if we look at hospitals, Buca Pharma Administration, and all of these good things that they're doing, much like Chapo Guzman is, emergency care, inpatient care, jobs, benefits, charity care, which we don't do enough of, and we sit back and we think, well, healthcare, we have the best healthcare in the world. We're the United States. No one does better than we do. Well, I obviously just proved that not to be true. That's totally untrue. So are we sitting in a situation of Stockholm Syndrome? I think so. I think that we really are. So let's call it like we see it. These are healthcare cartels. It's not a monopoly. They're not what they say they are. It's literally, truly a healthcare cartel, and they are damaging patients, they're damaging our profession, and they're damaging our economy at catastrophic levels. So what can we do about it? How do we dismantle it? You have to know your value, obviously. These are sort of common principles. Understand your value. We've gone to school for 20 years. You guys have brokered. Again, this is not just specific to doctors. Everybody has gone to school to learn about these things, so we have to be, if you have the information, be honest about it. And just really know your value and how you can contribute to that. I think it's, Dr. Imes mentioned this and alluded to it. If we leave, if we say no, and we walk away, and the brokers walk away, and the plans walk away and say, we're just not going to do this anymore, there is absolutely no way that this exists. Healthcare doesn't exist without the providers. Healthcare doesn't exist without the revenue generators. So we have extreme power that way. Educate yourself. Avoid complacency. You really have to care and protect your patients. Everybody talks about first do no harm. That includes financial harm. I think if there's things that you know, if you're going to provide a service to someone, you have to know how much that costs. You have to demand to know how much that costs and then relay that information. If you know, for example, a patient has to get serial blood tests for whatever immunologic issue they have, and you know that it's costing them $100 every time, but that they can get it for $8 down the street, tell them that. Even if you're involved in a system, tell them that. You have to be honest with them and help them out. We have to protect our patients, and our knowledge is our weapon. So how do we dismantle it? How can we find the courage to circumvent the healthcare cartel? You just have to have it. I mean, I'm going to go back to what Keith said, just do it. I think it's definitely not for the faint of heart. I think it's going to take a collective team to be able to do this over the course of years. It's now been over a decade, I think, with the FMMA sort of growing. And I have to be honest with everybody who wants to start a practice. If you build it, they will not come. I promise you that. It's very difficult. It's hard work. You're going to have to hustle. If you don't want to hustle, but you love just taking care of patients, join one of us. Come to any one of us that has a practice. If you're a physician or a nurse practitioner or a nurse or whoever, and you want to be a part of this and you just want to care for patients, you can do that. We're growing. There's over 1,500 clinics across the country now that are direct primary care clinics. Just be passionate about it if you can't do those other two things. I think Marty McCary is probably one of the best examples of this. He has worked for the system, continues to work for the system for many, many years, but he's had the courage to research it. He's had the courage to speak out about it. He's had the courage to write 2 books about it. The Price We Pay and Blind Spots are 2 books that you guys need to be reading if you haven't read them, but he's a perfect example. If you can't do any of that, stop complaining. Just stop it. No one cares. No one wants to hear about you and your problems. And if you think it's so easy, go do it. I refer you back to number 1. How do you build something like this and sustain it? It's just like any other business. We always tiptoe around the idea of like healthcare being a business. Well, it's a business. Okay, we make money. There's healthcare. There's the clinical part of it, but then there's healthcare. And so we have to have common sense. Price transparency, there's all kinds of different, these are more ideas than they are services that we provide, but it's really important. I put a whole slide on this, and I'm going to be over time, and I apologize, but just bear with me. We all know that this is a problem. Obesity is a huge problem. We were concerned about COVID, and we were concerned about the pandemic. This is the largest pandemic you will ever deal with in your lifetime. There are 4 million people that die every single year from obesity. It's the catalyst for 90% of the rest of our healthcare issues, diabetes, high blood pressure, high cholesterol, and everything else associated with that. So you have to be aware of that. You have to be honest with your patients. Don't be afraid. If you don't know about it, go back and learn some of the statistics. That the average North American consumed about 5 pounds of sugar in the early 1900s per year. Currently, we're consuming 150 to 200 pounds of sugar per year. We have the same pancreas, same human being, and the pancreatic dysfunction is the source of all of our problems. And if you don't know what that is, go back and learn about it. And I challenge you to look at statistics pre-1980s. Pre-1980s, obesity levels were static. After 1980s, things changed. It just skyrocketed decade after decade, year after year. And the reason being is because our food source changed. 1984, they introduced GMOs into the market, pesticides, chemicals, hormones, et cetera. You can all sit back and laugh and say, oh, that's just nonsense. The FDA allows 0.4 to 100 parts per million of Roundup on your food or glyphosate on your food, and that's really a safe allowable limit. But when you start to add all these things in together as endocrine disruptors and other catalysts for issues like this, it's something that we need to be talking about every day. And if you're not doing this in your practice, you're not doing your job. GLP-1s are not the answer. Okay, it is the answer for the GI doctors who want to start doing more procedures. It's job security because they are doing more and more endoscopies as a result of GLP-1s. It's not a magic bullet. It's going to hurt patients long term, and I think Marty's going to write a third book saying Blind Spots 2.0. But the 2 patients that you see on screen, those are our patients. You can do this in your clinics. You can look at programs like we use called Ideal Protein. It's a great program. It's really focused. We've been doing it now for 13 years, and we've had tens of thousands of pounds of weight loss over the last decade. Obesity is not a disease. Get that through your head. Argue with me afterwards, but you're wrong. I talked about this. Okay, those 0.4 parts per million and 100 parts, that's a pretty wide spread. That's a safe allowable limit for you to consume every day. Totally agree. But what if you're eating it every day for the next 75 years over your lifespan, 3 meals? That's 82,000 meals that you're eating with that little bit of safe glyphosate in your food. If I don't make it out of this conference alive, look to the dermatologists if they're in here because they're the ones that are going to kill me on the way out. Honestly, what is worse? Is it the sun, or is it the avobenzone, oxocrylene, or oxybenzone that you're spraying on your children? Skin is your largest organ in your body, and we lather ourselves up every day. I'm not saying that the sun is great and you should bask in the sun all day long. But just have common sense. Your patients are not stupid, okay? So let them know that you're not stupid. And let the community and the other people that you're working with, let them know that you're not stupid. Like, these are real issues. We know that these are carcinogenic. We know that they're endocrine disruptors. And we know that they're not good for us. So let's think a little bit more purposefully about it. How about use sunblock instead of sunscreen? These are easy things to do. So we a little bit about our business. We started, again, and I'll try and get through this quickly as well, but we started our program with direct primary care and medically supervised weight loss. We're talking about the how. How do you remain sustainable with this? Well, everything on the screen sells back to itself if you want to talk to the business side of things. If we start with medically supervised weight loss, we're getting people off of their diabetes, high blood pressure, high cholesterol medications. So we're doing direct primary care by default. So those people then joined our program for direct primary care. And the people who came in who were just doing primary care, which is a very slow growing machine in the state of Wisconsin, they would come in and they'd be overweight or obese or have some other underlying issue. And we'd put them right down to our medically supervised weight loss program. So these two things are very symbiotic. During those times, and I think from a sustainable practice standpoint, don't be tunnel visioned. Like, if there's something that you know you can do, add it to your practice, but add it intentionally and purposefully. If someone comes in and says, well, hey, my sister's got to get these labs drawn for this disease that she has, can she get those labs drawn even though she's not a member? Well, direct primary care members get everything that we have wholesale, right? So there's a wholesale value to everything we have. If you get a CBC in our clinic, it's $4. If you get an MRI, it's $315. So they pay us a monthly membership fee of $59 a month, and we give them everything else we have, labs, imaging, pharmaceuticals at wholesale cost. But if Judy's sister wants to come in and get her labs drawn, why would I not do that for her? Why would I not mark it up? Now, I'm not as smart as Mark Cuban, so I only mark it up to $8 for the CBC. So I'm not making really any money on that because there's staff involved and all that. But you provide a benefit to the community that they can come in and get a lab draw and then print that out and take it to their physician. They don't have to be your patient. So you can do this without a doctor's order. So you have to be adaptable. Adapt to your market. Adapt to the things that people want, that they really need. And every market's going to be different. If you're allowed to self-mutilate, why can't you draw 5 cc's of blood and test your cholesterol? Why does it only have to be twice a year because some stupid insurance company says you can only do it twice a year? I mean, that's literally the definition of insanity. So, like I said, I waited for about 10 years. We were finally able to do this. Keith said, just do it. So I finally just did it. It took me quite a while, but I think that his model that he has given to the rest of us to be able to do is great, because now you're looking at healthcare costs or surgical costs that are about 70 to 80% less than the system. Everybody does things a little bit differently. Everybody's prices are a little bit different. But you're providing a service now, not only for self-funded businesses, which is sort of a large part of the market, but individuals who don't have insurance, they can come in now and maybe get a hernia done for $3,000 to $5,000. That's a lot better than $60 or $80. And people who have high deductibles, so that you can really serve a good part of the market. But as adaptability goes, if you can continue, if you have the ability to add things like we added 2 medical grade hyperbaric chambers last year, why? Because insurance dictates that they only cover 15 different conditions per year. If you know anything about the operating room, most hoops that you have to jump through to get into the operating room are extreme, and we end up taking these people to the OR to cut their feet off or cut their toes off or whatever we have to do for these non-healing wounds, which is what hyperbaric is mostly used for. But there's about 100 internationally recognized conditions that hyperbaric is good for. So we said, you know what? For people with traumatic brain injuries or post-op wound healing, all these different things, we're going to try and add these hyperbaric chambers to our practice because it's a value add to the community. And so we've been able to do that well and do that off the insurance grid. So we've created, by being adaptable, created a mechanism to be able to offer many different services and value add services at effectively a wholesale rate or a close to Medicare rate, which I think is really valuable. So you have to look at what your market really is bearing. This picture has been circulating around with Tiger Woods and John Daly, and it's comparing a self-funded plan against a fully insured plan, and I think it's sort of fitting and mostly true. But that's really a market. If you're looking at sustainability, look at that market. 65% of the population works for a self-funded company. That's a huge market, and there's enough for all of us, okay? It's not like the competition is not really there because this is so many people. But you really need to understand their pain points. What issues are they dealing with, and tailor your offerings to what they have. Stop being tunnel visioned. If you go into an employer today and they say, you know what, I just don't know if I can do direct primary care. It's a big initial spend, but we have some really high costs on our imaging. Well, guess what? I get MRIs for $315. So if they say, can you just do your MRIs for me? Yes, I can. Don't say no to people. Just never say no. I learned that from my dad years ago. Don't say no. Just do some research and then come back to them with some answers. But you can go back to them and say, we'll do your MRIs for $550. Because they're not members, they're not doing direct primary care. So you can upsell that or mark that up if you want. And you can say, oh, bad doctor, he's marking things up and trying to make money. Well, it's a business, don't forget. And these people, they're not necessarily beholden to us, but they're still getting at $550. They're getting a much better deal than going to the hospital for $3,000. So take off the blinders, realize that you can do other things outside of direct primary care, outside of direct surgical care, because you have the ability to do that. Partner with TPAs and benefits advisors. Like, this is part of the team. Don't be afraid to go there, because there's more and more of them coming on board because they understand the value of what we provide. They understand the value of what they can get out of what you provide, because normally, years past, it's all commission-based, blah, blah, blah. Now there's a lot of static fees that they like to charge. There's a lot of different ways to skin a cat that way, but they're part of the team. If you bring them into a boardroom with you, you're going to have so much more success as long as you guys are on the same page before you go into that boardroom. And make it easy for them. I think that's the most important thing. If you're a provider, for example, or a physician or whatever, and patient comes into you, for example, you want to do patient care. You don't want to do sick care. You don't want to do protocol care. You don't want to do any of this garbage. If a patient comes into you, you guys all know this, and you've done a full history and physical exam, and you know that they have a soft tissue injury in their ankle. It's not a fracture. They make you get an x-ray first, right? Then you got to do PT for 6 weeks, and then you can see the specialist. Then you can get the MRI. Screw that. Just get the MRI, guys. Come on. This is like, it's so easy. Get the MRI, get them in to see a specialist. Guess who's going to be happy? Your employer's going to be happy because you got them back to work quicker, right? So there's decreased employee absenteeism. The patient's much happier because you didn't have them jump through all these hoops. And you got to treat your patients the way that you know how. You did the best thing for them. So I think that's really important. Lastly, Billy Graham said this: when wealth is lost, nothing is lost. When health is lost, something is lost. And when character is lost, all is lost. I think that's fitting for us, because I think that we need to maintain our integrity in our profession, our integrity for our patients, our character within all of that. And so I think as we continue to grow the FMMA and we continue to grow sort of this grassroots movement, not only for direct primary care, direct surgical care, the self-funded plans, the brokers, Health Rosette, all these things. These are all great things I think that we can continue to do, and you just have to have the courage to do it. Don't be afraid to speak up. If you know this information, tell your patients, talk to the communities, and we just have to keep doing this together as a team. That's all I got.